I'm a palliative, for those who have not met me, I'm a palliative care doctor in Parliam, India. Uh, and I'm the chairman of Parliam, India.
So we can move on to the presentation now.
Okay. So, happy Nurses Day, everybody. What a pleasure. I think more than half the people here are known to me, but many I have not met for many years. So, I'm so happy that the Nurses Day gave us the opportunity to say hello to one another. Uh, Rajalakshmi has particularly told me not to take too long. I shall be brief. Essentially, I'll be talking about three things. One, a little bit about the past, where we are coming from. A little bit about palliative care in the country, not only purely nursing side, but what's happening in the country. And very often, that national picture may not be very clear to many people. So, if Raju, if you permit, after that part of it, I would like to stop for a minute and take any questions. And then we will go on to a little bit about where palliative care nursing can move forward tomorrow. So that's the idea. Raju, next slide, please. This lady is familiar to everybody, and I hope everybody knows that she was a nurse when she started palliative care. There are a few doctors here in this group, and each one of us has to remember that palliative care had its origin from a nurse who cared when generally doctors did not care enough. She later became a doctor, and that's the time when she started the hospice. But it is important to remember that very often, as happens in hospitals, it is the nurses who really care for people suffering. Sometimes we get stuck at whatever Dame Cicely Saunders did. Like she looked after the dying people. So often palliative care is only for the dying. She looked after dying people with cancer. And in much of India, palliative care is restricted to cancer. But she herself, in her own career, totally acknowledged that palliative care should not be only for the dying, and also that palliative care should not only be for cancer. And we from the developing countries have another challenge. Uh, there are a few situations where palliative care becomes applicable in Western countries. Whereas here, primary care is very often very poor. So that you and I have to do more than what a Westerner does. Well, the Westerner may go to a state of finesse, which we may not be able to do with our constraints, but we have to combine more of primary care in our country. And hey, what do we have that the Westerner has less, but we have more? Is there anything like that? You know that anybody who wants to say something can raise the hand and Raju would unmute you. What we have more than in the West It's a stronger family structure. It's also becoming less in our country also, but most of the time for the majority of people, there are people around who can help. And actually, they do most of the nursing much of the time. Raju, next slide, please. Has everybody met this lady? Jilly Byrne, who was my teacher in the early 90s. She even now travels all over the country and teaches. And and I think everybody in palliative care in India has a reason to feel grateful to her. And I'll mention one more nurse. Jilly is a nurse, of course. And one more nurse. Next, please. That was Val Hunkin. Val Hunkin died of cancer many years back. But she was one who used to come to India twice a year and travel around India wherever we wanted her to go and teach. Most of us learned communication mainly from her. Jilly was a great advocate, while Hinken was concentrating more on communication. So, where we are today depends a lot also on what they contributed to us. So, I mean, that is just acknowledging them, the pioneers. Next, please. So, as I said earlier, I am going to brief you about where we are with palliative care in our country. Generally, we need to talk mostly about these three sides of the triangle. Next, please, Raju. Because when we talk about policy, unlike in some other, no, the previous one. Unlike in many countries, in our country, it's a fact that we have to accept that policy does not automatically mean practice. Policies do not necessarily get implemented. Therefore, this is again something that we are struggling with. Hey, does India have a palliative care policy? How many people think yes? Please raise your hands. I cannot see everybody, Raju, so you take the count. Do we have a palliative care policy? Raju, what was that?
Yeah, three of them, sir. Three of them raised.
Actually, thank you. You are pretty close, but India does not have a palliative care policy. What it has is a national program. A policy is a long-term thing. A program is something that is put in now. But you are right in another way, those who raise the hands. Let me ask another question. Does India's national health policy include palliative care?
One person has raised.
Sorry?
Only one person has raised.
Okay, so you should know that India's new national health policy, brought out in 2016 and amended slightly in 2017, fairly recent, does include palliative care. So, though there is no separate palliative care policy for Government of India, the national health policy does include it. And what we do have is something called National Program for Palliative Care. We'll talk briefly about it. And drug availability becomes a major issue in our country, particularly with the restriction on opioids. We all need to be ashamed that though we have been working on it for some more than 25 years, even today, pain relief reaches only a tiny, tiny, tiny proportion of the needy in the country. But again, where we are, I'll come to. And of course, the third side of the triangle is education. Education of professionals, education of nurses, of course, doctors, other professionals, also education of the public and awareness. Next, please, Raju. So, as I said, according to the National Program for Palliative Care created in 2012, central government gives money to state governments, but it is given only for specific purposes. Say, for example, if your regional cancer center wants it, the central government money is not available. But central government does give money for formation of a state palliative care cell, which where two officials can be appointed who can work at spreading palliative care through the state. Why am I telling you this? Because as palliative care professionals, you and I need to know these possibilities, how we can move forward. The reality is the money is there with the government of India. It is given out. Um, I understand that last year more than 20 crores were given to some 13 or 14 states. I don't remember exactly. Often it is not used properly because the state government authorities do not get enough guidance. There is money also for inpatient unit in district hospitals, including for appointment of nurses. Any question about the policy aspect? Excuse me, let me get it. Any question at all? With it, Raju?
You can raise your hand if you have any. Yes, ma'am. Yes. Meherul, ma'am.
Hi, sir. I was just keen to know. Can you remember, was West Bengal included in that policy that central government has given any money to West Bengal for palliative care project? If you can remember.
I do. I mean, I do not remember whether anything was given in the last couple of years, but soon after, I mean, 4 or 5 years back, money was given to West Bengal, and at the end of the year, it was not used at all. When money is taken and not used by the state government, subsequent uh, years, the dispersal becomes a problem. So I can check whether it was given in the last year or last few years, but to the best of my knowledge, it came to West Bengal only once.
Sister Jancy.
What all amendments are made to improve the opioid availability for the poor patients?
Oh, okay. Opioid availability. Raju, will you please move forward? Next one. So, in opioid availability, our problem was main problem. There are many problems. One was our law, Narcotic Drugs and Psychotropic Substances Act. You see on the top panel, you know that the WHO brought out the WHO analgesic ladder in 1986. And see how the consumption has been rising globally. From that time, thanks to Dr. Jan Stensward and his efforts to a large extent, consumption of morphine for pain relief rose in every other country, But in the same period of time, it came down drastically in India. The reason was our Narcotic Drugs and Psychotropic Substances Act. Next, Raju. This rather horrendous law, which was brought out in 1985, has now been amended. It took us 19 years to get it changed. I will not go into the complications in the earlier law, but today, Parliament has changed it in 2014, and the new law is fairly simple. But the problem is something else. The central government makes the law. Now it is applicable to every state. So if some drugs controller in some state says, no, we are not following that, remember, they are saying that they will not follow the law of the land. That cannot be accepted. We must act. What the catch is, individual state governments have to implement it. Now, we have worked with some of you in some other states to make sure that this happens. And thanks to Dr. Geeta Joshi and team, for example, in Gujarat, it has been implemented. It has been implemented in several states. But even where it's implemented, sometimes implementation is partial. So, sister, you were asking how it is to happen. It is fairly simple. Any institution which has one doctor with training in pain management, the law doesn't specify what that training is. That is left to the state government or the drug controller to decide. So if the institution has at least one doctor with any training in pain management, then they should have absolutely no problem getting morphine. All that is necessary is to apply to the drugs controller for approval as a recognized medical institution. And then once you have that order, you can just place an order with the manufacturing company and morphine should reach you. That's the theory. But anybody from Uttarakhand here in this team? Oh, yes. There was somebody from CRI, Dehradun, right? Or I mean,
Yes, sir. Suprinder ma'am is there.
okay, because right at the moment, 3 weeks back, I got this message from Dr. Aditi Chaturvedi that the drugs controller was asking for several documents, including a floor plan of the building. And also they were asked to go to the ministry or somebody. All that is illegal. So that will need advocacy. We don't have to go there with a gun and fight, but they need to be educated. People need to be educated about what the new law is. Anybody who wants to learn more about the law, the new law and how to implement it, etc., talk to Rajalakshmi, and we can easily organize a separate session on opioid availability. I'm not going to the details of the law now. Sister, is your question answered? Can I move on?
Yes, sir.
Raju? Now, in the field of education, fairly recent thing, okay, it is many years since Government of Medical Council of India started an MD program in palliative medicine. Currently, 2 institutions have it in Mumbai and Delhi, and a third one in Ahmedabad is likely to start this year. But the bigger development is in 2017, the Medical Council of India brought in for MBBS, undergraduate medical education, they brought in an program called 8COM, a module, new module to be included in medical curriculum. The students, medical students joining medical college this year, 2019, are supposed to start learning it. Now, unlike the law here, the medical council did not stop at just announcing the module. They actually brought out a program for giving training in every state to some teachers on how to include 8COM module. Now, this module, palliative care is not mentioned in the name of the module, solely attitude, ethics, and communication. But palliative care is included, pain management is included, end of life care is included. Most palliative care is included there. Of course, there is a challenge. Most institutions will not have anybody who can teach palliative care. And there are about 500 medical colleges in the country. So, when all of us get together, we cannot help everybody who wants help. So, it will take some time, but we need to work from institution to institution. Now, what is necessary? Why am I telling you this? Particularly because, okay, listen, we got the government to form a national program. We got the parliament to change the law. But our attempts with the medical council and particularly with the nursing council has been very, very, very difficult. At least thrice, I remember fixing up an appointment with the chair of the nursing council, going there, and then he was not there after appointments being fixed up, and no letters are responded to. I must admit that it has been very, very difficult. But this is essential, as you can see. So all of you, was somebody talking? I would request all of you to think about it. I mean, most of you may, and many of you would know a member of the nursing council. If a few of us put our thoughts together, maybe we can make some progress. Raju, will you take a head count? Anybody who thinks you know some
So your sound is
and
breaking.
can talk to them, please.
Sir, your sound was
My
breaking.
voice is breaking.
Yes, sir.
Oh.
Sir, it's okay now. I think you can speak.
Yeah. I mean, but if it breaks again, I'll switch off my video and talk.
Okay, sir.
So I was asking you, I was asking the group, does anybody know a medical council member close enough to talk to them? Yeah, raise your hands if you can. Raju, did we get any?
Not yet, sir. Anyone who knows? Anyone from medical council?
No, nursing council, sorry. They say medical council, apologies.
Okay, from nursing council, anyone knows?
Not the state council, that is not of use. The Indian Nursing Council. Anyway, yeah? No. Okay, so this is a priority for all of us to get together, the nursing group to get together, form a program, not only for inclusion of nursing, palliative care, nursing education, there is a little bit, that's not enough properly, and also to make a plan for its implementation. Next, Raju. Okay, Raju, go back. So we talked about the policy, the opioid availability, and about education. Before I move on, does anybody have any question about any of this?
Any questions? Please raise your hands.
Okay, Raju. If there are no questions, we'll move on. Next.
Ma'am, sir, 1 second.
Yes.
Maherli ma'am has one doubt.
Who?
Maherli ma'am, you can speak.
Can you hear me? Can all
Yes,
hear me?
we can. You can speak.
I know everybody will tell me question bank now, but I was thinking that as the MD palliative medicine has included to the Medical Council of India, if one day comes that MSc palliative nursing will be included in the nursing curriculum, I think that would be wonderful for a lot of nurses, those who are trained in palliative care. It's not
Yes.
a question, just a thought.
Yeah. I mean, just that is certainly needed. Personally, I thought in MBBS also, MBBS was inclusion. MBBS was more important than starting an MD. Both are important. Similarly, and masters in nursing also is essential. And about that, one more point I have to say. I'll come to that later.
Sir, Sandra ma'am also had a doubt.
Sandra? Yes, Sandra?
Okay. Here we have got every year we have 2 modules with Nursing Council of Meghalaya on attitude, ethics, communication in palliative care.
Okay, very good. Raju, please remember to ask the Meghalaya team if they can share later. You send an email, can share the module. That will be very useful. If you are happy to share it with everybody, we can do that. Thank you.
Absolutely.
And congratulations on getting it done.
Thank you.
Raju, go on. Okay, before I end, I have this question. Very often the question arises, who should be leading palliative care delivery? Doctor, nurse, somebody else, administrator? And thinking as a patient, I would like the most committed person to lead. You know, in the West, many hospices, many palliative care programs are led by nurses. The director of the hospice is in many places it's a nurse. Not necessarily. It can be a chaplain. It can be a doctor. Uh, many people can, but I am looking forward to the time when nurses take the leadership in running palliative care service. I'll also say why I say that. I'm not just arguing for upliftment of your profession. I am talking selfishly because when my time comes, when I am a patient, who is likely to be the most helpful for me? Again, it can be very variable. If I am in terrible pain, Dr. Pratyush Bhattacharya may be the most useful person for me at that point of time. But thereafter, during much of the remainder of my life, it is the nurse who is likely to make the most difference for me. And for the very reason, I think nurses should come up more in a leadership role in palliative care. It is not easy because in our country, medical profession is very much doctor-led. And so this is tough. But all of us should aim for that. So if that is to happen, Raju, next please. The nurses, palliative care nurses, need to build their own capacities. Now, I'm very thankful to Dr. Ann Broderick, a doctor from Iowa who comes and helps us every year, for identifying 2 years back that one of the things that we in Trivandrum should do is to empower the nurses more. I mean, it was so obvious, but somebody had to make a plan to do it. Otherwise, I was saying yes, 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 and but I was not doing anything. So what she did was, one, she said if the nurses are to get more respect, more authority, they should be armed with more knowledge. She got permission for anybody in India to uh, undergo the course, an online course. It's free. Just ask Raju, anybody who is interested. I would encourage everyone to do that. It's not only for nurses. Doctors can do it, social workers can do it. But this is quite empowering. So we need to learn more. Earlier, you were mentioning about nursing education. Again, we need to empower ourselves. Another thing that Anne Broderick introduced in our team was that every day in the morning, before the inpatient rounds, the team gets together. Multidisciplinary team gets together and discusses patients who are admitted. Now, this presentation is led by nurses. The nurse makes a beginning and says so and so. This is what happens. This is what's happening. This is what we are planning to do. And yet, only day before yesterday, I was talking to 4 of our nurses, and I think it was Sridevi who said that this was the one thing that they felt was most empowering. They automatically started reading more, learning more. And the third thing that we started only day before yesterday was to do an online course. Was to do a course for our team. We can do an online later if Raju finds that there are interested people on just how to teach, the method of teaching, not necessarily what we went through in classrooms, lectures and lectures and lectures. Generally, nursing education is so much more modern and need-based than medical education. So you are already there part of the way. So these are some of the things that we have done. But I think everyone needs to, on Nurses Day, you all need to sit together and talk about if you are to have more knowledge, more authority, what are the ways in which you will have to empower yourself? Next, please, Raju. So that was from the patient's point of view, my point of view as a potential patient. But from the team's point of view, now we need the nurses to be teachers, to mentor others, to counsel others, because very often problems within the team, like the team members' individual issues will have to be dealt with, and very often it happens that either it's a social worker or a nurse. And as I said earlier, as we advance, more and more nurses should come into management and into research in palliative care. Next, please. And again, from the point of view of the patients, I think we should move beyond just what are technically seen as nursing issues. I know many people do it. I was telling my colleagues the day before yesterday that someday what I would like to see is a sight that is very familiar in Western countries. When you, and I know everybody is busy, but the nurse is there very often, at least in the inpatient units, around the clock. If there is a lonely patient, when I am there tomorrow, and if I am just lying there, when you have some spare time, just come and sit beside me. I may be just yearning for a human touch. And if you are feeling generous with your time, come and tell me, come and ask me. Tell me about yourself. Where were you born? And what are the important things for you? What is it that you enjoy doing? And as I speak, you will find out what are the most important things. And if at that time you say, oh, really, you did all that, I admire you. If you say it sincerely, then I'll feel on my last few days, my life has not been in vain and somebody appreciates me. So, this, when we are inundated with tasks, registers to fill, nursing notes to be made, accounts to be kept, so many tasks, sometimes this goes into the background. But when possible, I am hoping that as tomorrow's palliative care nurse, you will do that for me. Thank you very much. Raju, I know after I started, it has been already half an hour. We did have some discussion earlier, and we have 2 more presentations to go. So I'm leaving it to you how to move forward.
Yes, sir. So the session is open for discussion. Any questions you wish to ask? Raise your hands if you have any. Yes, ma'am. Sister Anna,
Yes.
you can speak now.
Actually, I don't have any question for sir, but one thing to share, good thing that is happening in our center in Karamsat, that since last 3 years we are training students in palliative care, especially those who are learning about the cancer disease. So in GNM course, it is SY GNM students, and in BSc, it is third year BSc students. So since last 3 years, we were giving just 10 hours of palliative care classes to them. And from this year, we are going to have 3-day workshop like for the students. So total 60 students take part in that, and I'm happy to share that.
I think everybody should applaud the Anna's initiative in Karamsat in Anand. Well done, Anna.
Thank you, sir.
Any more? If not, can we move on to next presentation? So over to you, Sister Anna.
Yes, thank you. We have already done with the introduction part, so let us have next slide, please. So these are the 4 components of our care, and with that perspective, we also include these 4 things for the palliative care nursing too. If any one component is missing, then it is not a complete care and we cannot serve the patient. And that's where the involvement of all the disciplines apart from nursing come into picture. and patient, keeping in mind patient in center and nurse being coordinator between the team members. And that's where, friends, we are here celebrating our Nurses Day. Next, please. This slide, of course, shows the conventional method and the palliative approach. You all know these things, and palliative care is a unique approach in taking care of any patient, be it the end of life care or the person who has just entered and who needs palliative care, thinking that it is going to be a chronic condition. So from day one, start giving palliative care. We also know, and perhaps patient and his relatives also know, that death is inevitable reality, but still we neither want to hasten nor we want to postpone it. So these two very important things we have to keep in mind while giving care to the patient. Next, please. I feel one more thing is necessary here before we have this slide is the 10 commandments in palliative care. And the commandments are essential principles and always should be kept in mind while giving palliative care. Keeping patient in center and providing maximum relief from pain is very essential. Here we can see the 7 C's of palliative care. I see these C's as the closely knitted threads of a beautiful cloth. If we try to remove any one thread out of that beautiful cloth, then the whole cloth will be ruined. So same thing here: communication, control of symptoms, continuity of care, carer support, care of dying and bereaved, coordination among all the team members, and continuous learning. One should never end learning, maybe from within and from others. So same thing happens in the palliative care uh, needs of the patient. Compassionate care with loving words, keeping in mind not only the patient but family also, and not only during illness but after the death too. That makes the sense. Next, please. Yes, this is role of nurse. After seeing these basic things in about the previous slides, let us see the aims. They are the relief of suffering, control of symptoms, and restoration of functional capacity. Any kind of suffering should be eliminated. So symptomatic care is very, very essential for any patient needing palliative care. And don't forget that keeping the principles also in mind, scientific principles, whatever are involved in that. That's why nursing is called art, science, and spirit, I should say, or you can say vocation too, as without instilling sensitivity, empathy in palliative care, it is not possible to work with skillful hands, and using your head and putting in all your heart is essential. Next, please. Functions of nurse. There are plenty, unlimited, you can say. So many things are expected from the nurse. There is no end of the list. There are 3 main important, as sir also said in his slides. I see the nurse as teacher, motivator, and comforter, of course, and being a manager for all the day-to-day problems in caring of the patient is very important. Next, please. Among many models given for the nurses and on nursing, this model I find very appropriate for the palliative care nurses. You can very well see C for communication, O for observation, M for mindfulness, F for family support, O for openings, R for relating to others, and T for team. Uh, Without none of this, it's possible to give palliative care. Next, please. This picture says it all. Palliative nurse is the one who affirms life, promotes quality of life, provides treatment, and supports the family. Next, please. Let us see today the palliative care from the care plan point of view. I know all the nurses must be preparing it. So first step comes as assessment, right? Okay. So assessment of patient's need is very, very important. Unless we do proper assessment, we cannot do the next step. So from the point of view, all the 4 aspects of the health, if you are assessing a person, look into his normal needs, day-to-day problems, whether he is able to do it, communicate with the person and the family also, and whether communication is very important, and one should find out whether the person is comfortable with you and family is also comfortable with you in sharing their problems, or are they feeling isolated, and assistance should be given accordingly. So communication is very important and it should be effective also. Next, please. Planning any care, and in that sense teaching also. Involvement of person himself who is undergoing treatment is very essential, because I find that if there is a will, there is a way. So if the person is positive for his or her condition, uh, this becomes very essential. And looking at life positively creates more positive vibes, I should say, around anyone. So if person accepts and we are also accepting his condition, then it is not difficult to provide him care. And don't forget to take into consideration about the limitations also, and help them to overcome these limitations. Next, please. Interventions. There are plenty of interventions we do every day, and next 2 slides are for this. And there's a long list of do's and don'ts on the part of nurses and the members of healthcare team. Spend enough time, quality time with the patient also and relatives too. Understand their concerns, that is very important, and finding solutions and keeping in mind while giving solutions or solving their conflicts about their social and spiritual aspects, because otherwise we also can land up in a problem. Responding to pain is also important. Next, please. Many times nurse themselves have to work as physiotherapy, showing very simple exercising and creating awareness also and confidence in the person himself. Because if the person gets some one step at least in confidence, then he will have a very good outcome also, and less pain also. Next, please. Okay, I feel 1 or 2 more slides are remaining here. And in that and in our center also, and most of the nurses must be having the work like taking care of the bedridden patient and prevention of bed sore. So in that, keeping the skin adequately moisturized, turning whether person is able to turn himself or needs assistance from relatives or from nurses, and of course the access to the comfort equipments like air bed and all. That too is sometimes very costly for patients. So economic point of view, there are many social agencies also who provide at many very minimal rate to the needy person. So we also, as nurses, we should know the sources from where they can get the help. Next was the care of wound, and in that we have all learned how to do dressing and maintaining not only the, maybe sometimes only clean techniques are possible, not even sterile, but the thing is that it should not get worse, and secondary infection should not take place, maggots should not enter into the wound, and it should not become very smelly and all that, because the caregivers are also find very difficult. Sometimes patients just come to hospital just for dressing. We find many such patients in our hospital, but unfortunately many of them, they don't have enough money also, because they have to travel along for so in such cases we need to teach the carers, and carers also sometimes they are not willing to do dressing of their keen ones. So many times it happens. I know one patient, he had very bad wound and he was having oral cancer, and he said, I am ready to do my dressing myself. So we all were very much surprised. So we said, well, you can do in the beginning, but maybe on later stages it will become difficult. So we tried to help his relatives and come over the problem. Then mouth care, controlling halitosis to increasing salivation, uh, that is important for improving taste is there. Then lymphedema bandage is also we need to teach. Then stomach care. In stomach care, many times it happens that patients are not willing to do their self-care in the beginning. So for that, we need to encourage them. Many times they feel isolated. So the training should be given. Of course, diet also should be taken care of, and so that there is prevention of gas formation. Next care was catheter care and prevention of kinking to changing it at regular intervals. Very few patients are affordable for silicone catheterization, and some patients do their self catheterization, so we encourage them, and otherwise they need to come to the hospital for regular changes. Of course, nutrition is very important for the patient. Adequate diet, again, preferences of the patient is important, and adequate supplements so that the patient can maintain his or her health. That is essential. This slide shows us the part of hands-on training for the caregivers. As we discussed before also, it depends on the carer's willingness. And one very important factor is the person whether is able to spend enough time with the patient, the caregiver, I mean. So these two factors are important. And we need to see their understanding level. Of course, we need to teach them the few scientific principles in their own language so that they can care the needy person effectively. In all these things, there is one important word, and that is patience. Half the battle is won if we nurses have enough patience in ourselves, because many times the long standing hours and long time in teaching and the carer taking long time to understand the things, many times nurses become impatient. So on our part also, while teaching, we have to be very patient. And of course, the evaluation of the caregiver, whether the person is doing it in proper way or not. Many times, carer is engrossed in the patient so much that he himself starts neglecting his own health. So we need to tell the carer about the importance of maintaining his or her own health so that he can give enough time to the person. And of course, the pain management, we know using WHO ladder is very important. Next, please. Yes, psychological care and spiritual care. Various, there are many things. Spirituality is not just the religion. It is the, I feel that it is, the meaning says that it gives purpose to life, and that it keeps us connected to happiness. We feel life worth living, and gives us utmost satisfaction. So if we work accordingly, the person who is giving care also work accordingly, then the patient is getting all the benefit. Psychological care and emotional support is also very important, and the person who is giving care should also find some relaxation techniques like yoga, or developing hobbies, or even distraction method. Okay, for patient also these things are important. So many times we also need, just by simple deep breathing techniques also help many times with the patient and the caregivers, and of course we too, so that our stress level is reduced. Next, please. Evaluation of caregiving, the last point in our care plan. Well, without evaluation, we cannot survive, and we cannot find next step also. So anyone, whoever is giving care to the patient or any needy person, this step becomes very essential. Then only we learn whether any changes are to be made. And of course, many times many crises also arises. So how to handle crisis is also important. Try to find out the cause, and act swiftly and mindfully. That is essential. Next, please. As I said, while caring for many long hours and seeing all the pain around us, we also become very exhausted. So our own care is equally important. This whole week we had different programs, and in that we had invited motivational speakers also. So we also had this one common point which was decided by all of us, that we should spend at least 5 minutes for ourselves, not if possible half an hour, so that we are at peace. Then only we can make others at peace. So that is very important. And share problems with concerned persons, try to find out the solutions, recognize signs and symptoms of your own stress, and learn to relieve them. We all have one or the other method of uh, getting relief. Next, please. So in a nutshell, uh, these are the aspects we should take care. Identify the problems, adaptation of management to home-based care or institutional care, I should say, caregivers education and their issues to be addressed, and regular reviews, maybe by phone call or by their home visits or their follow-up visits in our hospital. So in short, I should say, for nurses, sky is the limit for your chosen path of palliative care. Thank you.
Thank you, ma'am, for the presentation. Anybody wishes to give some experience or suggestions or something for this presentation? Sir?
I have a question. Anna,
Yes.
ordinarily in our nursing colleges,
Yes.
teachers do not act clinically.
Yes.
Nursing professors do not do any clinical work. From the photographs, it appears that you are very different. So tell me, what do you do?
Thank you, sir. Sir, we have, of course, as a tutor or at professor level, we do have clinical rounds. We do have to visit the wards with the students. And at least it is expected from us to spend minimum 3 hours in our clinic. And sir, I remember your advice, and I do visit our palliative care, OPD whenever possible. At least not every day, that at least twice a week. I make it a point that I go there and I sit and see the patients because that gives me worthwhile also, okay, that I had taken training and I am in touch with the patient. And students also, they find this OPD very, they have started going to the home visits also. Yesterday only they had gone to visit a patient who was having breast cancer and breathing her last moments, and they were able to do dressing very well. There were a lot of maggots and all that, but they learned a lot how to do dressing there, and they were very happy and gave me a response that, madam, we like to work in this field. So I was also very happy that, okay, I'm able to instill some good qualities in them.
Very good. Very happy, Anna. Congratulations.
Thank you, sir.
Sir, Dorothy ma'am had a question.
No, it's not a question actually. It's just sharing my view. I'm working as a home care nurse in pain relief and palliative care. I'm impressed with what Sister Anna had presented. It's the same scenario in our setup also, where in home care they are very palliative care. Being a palliative care nurse is a very challenging because you are in a patient territory and you have to patiently listen what the caregiver and the patient says. There comes a time when a patient has a different view and the caregiver has a different view, and it's very challenging. The most challenging these days I find as a home care nurse is the dietary part. The diet is the more important concern what they have, especially end of life in a home setup. So Dr. Gayatri has been teaching us a lot about this, and we are practicing also. But I just wanted to ask Sister Anna, how do you deal with end of life patient who has this thoughts of diet, what to give to them, and they have repeated questions and concerns since the patient is not able to take anything in a home care setup? Like, how do you deal with it?
I myself have seen this problem in my own house, I should say. It becomes very difficult sometimes when the person is, our loved one doesn't take food. It is very sometimes depressing also, but whatever the person likes, uh, that should be given to in whatever amount. I mean, they may not be able to complete the whole meal, but at least few spoons, that gives them lot of satisfaction. So I feel that that is very important, that they get satisfied in whatever way. Many times they don't have any energy to sit up and like that. So very small amount, maybe mixed in liquid, making it liquid form or semi-solid, in whatever way they can swallow. This is a challenging job, of course, because all the time we cannot have I mean, whatever menu we make, say for example, they should have 1000 calorie per day, but many times it doesn't make any sense. So what I feel is that whatever they can take, how much they can take, should be provided to them. And so all whatever is available at their own house can be given to the person. Otherwise, many times they don't just neglect the food or say no, I don't want to eat anything. So that's how I feel that should be dealt with.
Yeah, we do the same thing, ma'am. When we go to the home care setup, but it is very challenging to convince the family member.
Yes,
Actually,
forcing is no problem.
yeah, they are like stick to that thing. Why is he not eating? He used to eat like, and now why is he not eating? So that's a greatest challenge I feel, and I want to share my feelings. Like if nurses can be trained to convince the family members, the care will be even more easier. Of course, we thankfully we have our counselors who do help us during our counseling sessions, and we are not left alone, So when we inform or when we explain the caregivers, it's challenging, but in 2 or 3 sessions of counseling, we are able to do that. I just was wondering how different it is in your setup. Thank you.
So any more questions or doubts or something? So can we move on to Sandra ma'am on her experience with palliative care?
A very good afternoon to you all. Am I audible to you?
Yes, you are.
So it is a privilege and an honor, and it gives me immense joy to be able to share our experiences as nurses here in Palliative Care Unit Negrims, the easternmost region of India. We have come to recognize that the work is tough indeed, as it needs our combination of the art of caring and the science of medicine, and a willingness to step out into the unknown, meeting patients and families under stress, and often without the comforting presence of the doctor on our visits to patients' home, which reflects compassionate individualized care regardless of the environment. But we have come to appreciate that this work brings its own rich rewards in the patients' and families' faces as their eyes light up on seeing us. For example, seeing patients who have remained confined to their room or bed for weeks and months after having shared with us their thoughts and symptoms, shared a cup of tea with us, they will come out of their room and seeing us off at their doorsteps as we leave. And working with palliative care patients, we encounter death, sorrow, and emotional situations in our everyday work. The experiences we've gained is incredible. We've cried a lot and we have smiled a lot too. And we've always been sensitive to issues faced by our patients, young and old, and the families. And we are trying our best to meet their needs and face the problems together, not because we are paid for it, but because we all have that affection towards our patients. Furthermore, working in palliative care entails becoming close with the patient and the family, which at times may be emotional for us. And every time we get a call or hear the news that this or that patient died, we become emotional. But and it's difficult for us sometimes to let go because we've built that bond with them. But as we all know, the surest thing after birth is death. So we're happy that those who have gone, they died a peaceful death without pain and suffering. And we've always thought that it's impossible to bring about changes in people's life. But nothing is impossible if we have the passion, dedication, teamwork, and the attitude to look at situations from patients' and families' perspective. And one of the most satisfying experience that we regularly had is when family members come to us thanking us for being there with the patient, supporting the patient and the family, and comforting them until their loved one died. So not only did these experiences ignite our enthusiasm for working in palliative care, but it reminds us every day that we are called for this and that the key to success in being able to help more patients is hard work, teamwork, and dedication. And one of our major group up was we had a patient who needed a 24-hour subcutaneous infusion for managing his pain. So we gave him our syringe driver, which was given by our dearest respected Sir Rajagopal. And unfortunately, when the patient expired, the family burned the syringe driver. And it's unfortunate for the syringe driver, but we're also happy that the patient had a peaceful death. He was free from pain. And I hope, sir, you won't hold this against us.
But it was replaced.
Yeah, but it has been replaced. Yeah.
By the patient's family.
By the patient's family. And all in all, this is an undoubtedly fulfilling experience. And being in palliative care has really changed our perspective towards patients as a nurse and taught us how to treat them as individuals who are unique in his or her own ways and addressing his or her physical, psychological, social, and spiritual needs. And not just as a patient with a bed number or a patient with a disease only, where the disease is not the central concern here, the patient is sovereign, and our intent is to heal even if cure is impossible, so that even if the body is disintegrating, the person can still become whole. And we're also glad to inform you that we have conducted around 3 continuing nursing education on palliative care, and more than 700 nurses have attended our workshop from all over the state. And so that is the good news. More nurses are learning about palliative care. They are being trained on palliative care because it's not necessary for them to work in a palliative care unit to practice palliative care. Even in wards, ICU, they can always practice palliative care because that is very important. So we wish everyone a happy Nurses Day and God bless.
Thank you, ma'am. So training such a good number of nurses is indeed a very good job, ma'am.
We have got the Nursing Council of Meghalaya on board, and they are very happy that we are running these modules for them. So they get Nursing Council credit hours.
Okay. Thank you, ma'am. So I think we can now hear from Rajni, ma'am, about her experience in palliative nursing.
Good evening, all of you. Nice to see all of you. Thank you, Dr. Rajagopal sir. Myself, Rajni, working as a nurse in Kangra, Himachal Pradesh. Dr. Parveen and Dr. Rekha started palliative care on 12 July 2016 and at Tanda, Kangra, Himachal Pradesh. I learned a lot from them and they work very well in palliative care. In a short time, I want to share some of my experience during my practice in palliative care. First, I realized that the power of love and care that we give the patient and their family along with nursing care and during counseling. Then the strength of fight with their disease increases even more to cope up with their sufferings of love and care. Second thing that I learned the right way to work and good communication skill from
Hello, ma'am.
palliative training. I went back on my job.
Ma'am, one second. Ma'am, can you disable me? Okay, ma'am, you can speak now. We have disabled your video, so it will be clear.
But after palliative care training, I went I wife see a breast. He became shocked and asked, "Do we know each other?" I said no. Then he said that you are the first one who told me so lovingly and asked me to sit. He cried and again said that I gave my 40 years to serving people in medical field. But today, no one listened to me, my problem. He gave me blessings. Then I feel inner satisfaction and I realized how many blessings I got from just offering a chair. In nursing care, we were learned to stay away from the patient's bed. But I remember when I sat on the bed of the patient and talked to him, I feel the tears of comfortness in his eyes. Due to empathy, now I feel the fear of death in the eyes of the patient and also the fear of losing loved ones. But during practice, I learned how love and support reduce the pain and sorrow slowly. I saw an important role of counseling in palliative care. People run for treatment. In some cases, they think they will be cured. They does not know diagnosis, prognosis. They spend a lot of money. At the last, when the physician does not have to do anything, suddenly doctor tells the truth, which is unbearable. They get very much depression. So I learned care of the caregiver is important part because he is going through too much sufferings. I learned at last how did the morphine help us when no medicine worked, because it is so difficult to put the patient at home if there is no control of symptoms. In hospital, we had learned try to save the life of the patient till end and even during death. We did not worry about his pain and quality of life. But in palliative care practice, I teach the quality of life and a peaceful death or death with dignity. During home visit, I found people's problem like due to lack of clean clothes, the vehicle has to be hired, which is very expensive, and their financial problems, lack of knowledge, etc. After the death of patient, we could not help a lot with family because we did not have the means, and because of government sector, we had some limitations. I too faced many problems due to jealous factor, but courage the courage of the patient was very encouraging to me. Really, I learned so many things from, and every day I learned a lot from every single patient. Palliative care is beneficial not only patient and their family but also for all of us. Thank you, Dr. Rajagopal sir and their team who shows me a right path. Thank you so much.
Thank you, ma'am, for giving such a very good explanation.
Thank you.
So, anyone there to share their experience?
Hello, everybody. Thank you all for your experience sharing with us. Let us fulfill the dreams of Chairman Dr. Rajagopal. Okay.
So, thank you all for logging in. I know we have passed our time. So, hopefully, we can keep this group alive, a group of palliative nursing who are doing wonderful job in their profession. So, we can see sometime later. Till then, we are logging off. Bye all.